Good evening, everyone. I'd like to welcome you to the inaugural event in Boston College's Park Street Corporation Speaker Series, Health, Humanity, and Ethics. We're deeply honored to have Dr. Paul Farmer here with us to launch this speaker series. As this is our opening night, we want to begin asking you to join us in thanking various people, some here tonight, who've helped to get this speaker series underway. I'm Amy Boski, professor in the English department and director of BC's new and rapidly growing minor in medical humanities, health and culture. Along with my colleague Jim Keenan, who you'll hear from in a moment, we've been asked to direct the new speaker series over the coming years with the goal of bringing to campus local, national, and international leaders to address timely issues in the intersecting fields of health, humanities, and ethics. In this, we see BC taking an important leadership role in this vital arena. We owe a debt of gratitude to the Park Street Corporation for their generous gift, which so well aligns the late Father Quinn's interests with the mission of Boston College. The Park Street Corporation was founded in 1971 by Father Quinn, a Paulist priest with a passion for housing and civil rights. As his niece, Kathy Sullivan, who's here tonight, remembers, Father Quinn founded the Park Street Corporation with the goal of bringing people together to solve problems. He convened Boston business and political leaders at his apartment for breakfasts, each with a set discussion topic on law enforcement, housing, education, energy, or healthcare. Former attendees at these breakfasts credit these meetings with germinating ideas that shape public policy at the state and city level. Sustaining that legacy, the Park Street Corporation, with the support of Father Quinn's family, has made possible this new endeavor at Boston College, retaining Father Quinn's cherished goals of bringing people together and using conversation to press for change. For this, we owe thanks both to Father Quinn's family and to the Park Street Corporation. Special thanks are due to Joe Fallon and Leo Corcoran, representing the Park Street Corporation Board, and to Kathy Sullivan, who connected the right people while also caring for Father Quinn as his health was failing in the year prior to his death. Kathy, Joe, and Leo, a heartfelt thanks from Jim and I, from the medical humanities minor, and from the entire Boston College community for your generosity and support. In remembering and paying tribute to his legacy, friends and colleagues remark on Father Quinn's capacity to engender meaningful conversation. That word, conversation, was central to Park Street Corporation's endeavors as it is now to ours. From the Latin, the word suggests intimacy and friendship, living with, living among, as well as transformation. To converse means to turn around with. Like the Park Street Corporation, Boston College's medical humanities minor is grounded in conversation. In fact, the minor began several years ago with a group of faculty members. We met over lunch and at breakfasts, but similarly, we met in conversation to think a little bit together about what an interdisciplinary program in health and healthcare might look like. Our program, which began as a pilot and only became an official minor last year, is thriving. We will graduate more than 50 minors this May, and I think that all of them are in the room tonight. This minor is part of a growing worldwide recognition that the most urgent questions about health and healthcare practices are interdisciplinary in nature. After all, the word health, which in its etymology is associated with wholeness, is implicitly bound up with issues of culture, ideology, and social justice. In this regard, as in so many, it is hard to imagine a more relevant or esteemed speaker than Dr. Paul Farmer, who has changed the conversation about healthcare for us all. And now my colleague Jim Keenan will say a few words about Dr. Farmer.
I just want to say a few words about Paul. The first time I contacted Paul was about 1999 to invite him into a collection of essays on Catholic ethicists on HIV/AIDS prevention. And he did a wonderful article with David Walton trying to talk about the real problems that were endemic specifically to Haiti and what were the obstacles for working on prevention. And when I read it, it was kind of unpredictable, and that's been my encounter with Paul ever since. In 2000, the book came out, and so I invited him to my class, a group of graduate students at Western School of Theology in 2002. So he decided to come with Tracy Kidder, who was at that time doing a book that you may have heard of. See, they do laugh. He wants you to laugh when he does a joke like that. I'm doing this to prep you so that you know that when he does this, you should be laughing a lot more. Anyway, he came to my class, and it was hysterical. You know, I had all these different graduate students there wanting to talk about public health, and there was Paul just going on and offering a great deal of insight, but a lot of his humanity, and I think that that was really rather key. In 2004, I went to the AIDS conference in Bangkok. There were 25,000 people there in Bangkok at the International AIDS Conference. And people would say things like, have you seen Paul? Now, if somebody said, have you seen Jim? They'd say, Jim who? But whenever anybody said, have you seen Paul, among these 25,000, we all knew who they were talking about. That gives you an idea of the way that Paul has a fairly broad circle. In 2005, he came here as the inaugural lecturer for the convocation series that we now do with freshmen each year. And he was the first presenter in 2005 for the class of 2008. The last time I got contact with Paul was in Nairobi. I had just gotten off a plane in Nairobi, and the cab driver handed me a message. It was from Paul and Jenny Weiss Block. They had just hired that driver to take them from the airport to where they were staying, and they were trying to get the driver to take me to where they were staying because this was a joke of theirs. These are jokes in Nairobi. One of the things that you'll be struck by, anybody who knows Paul, it's his humanity. But it's a humanity that's known for its compassion and for its wisdom, its insight, its humor. But more than anything, I think it's a commitment. You know, I remember a year and a half ago in my AIDS class, we had two students, former students, alums, who had taken my course on HIV/AIDS, and now were both working for Partners in Health. One of them was Brianna Norton. And they were both coming, and they had just told the story in the class of what it was like to help all the people from Partners in Health who were going to Liberia to work on Ebola, and how one of them had actually been the legal witness to all the last will and testaments that all these people had written out. It would get you an idea of what it means to be a full human being, what it means to have such a humanity that when you realize something needs to be done, you're the first to go. And so it's a real pleasure for me to hand this over now to Chris Reynolds, who's going to give a much more formal introduction. We thought it would be more appropriate to have an undergraduate introduce Paul to this university.
Good evening. And again, welcome to the inaugural event of the Park Street Speaker Corporation Series. My name is Chris Reynolds. I'm a biochemistry and theology major working in public health, and I'm beyond humbled to be introducing our speaker tonight. Like so many of Boston College's students, I've been looking forward to this moment since I first heard Dr. Farmer would be speaking here. I first encountered Paul Farmer last summer through a reading of his work In the Company of the Poor, a collaboration with Gustavo Gutierrez, which looks at liberation theology and healthcare as a partnership. As I read this book, the words seemed to pop off the page, and they ignited something powerful inside of my heart. Paul Farmer, the way he talked about accompaniment and suffering with the poor, was able to put into words exactly the type of physician that I aspire to be. I could not put the book down, and it changed my life. To say that Paul Farmer has been an inspiration to me and to members of our Boston College community would be an understatement of his true influence. His writings and his lived philosophy of healthcare equity actively exemplify a clear preferential option for the poor. Boston College challenges us to be women and men for and with others, and Dr. Farmer's explanations of medicine, social responsibility, and concern for the poor exhibit a lived example of leaders our university strives to cultivate. His condemnations of structural violence and certainty that these human-created systems of oppression and injustice can be dismantled aligns directly with BC's Jesuit ideals. You know, Dr. Farmer, I haven't exactly cleared this with Father Leahy yet, but given all the similarities between you and Boston College, don't you think you'd feel a lot more at home here than at Harvard? Tonight we are privileged to have joining us Dr. Paul Farmer, a physician, anthropologist, activist, and advocate committed to bringing gold standard healthcare to the world's most marginalized populations. Dr. Farmer graduated summa cum laude from Duke University, after which he spent a year living in Haiti, experiencing the realities of this hemisphere's poorest nation. He would continue his education at Harvard Medical School, earning Ph.D. in anthropology and a degree in medicine. While at Harvard, Dr. Farmer simultaneously expanded his engagement with Haiti, co-founding Partners in Health from the humble beginnings of a local bakery and a rural clinic. As one of today's most prominent international organizations, Partners in Health works in a dozen countries, including Haiti, Rwanda, and Peru, and has been able to combine healthcare delivery, academic research, and models of accompaniment to care for the world's poorest. Currently, Dr. Farmer is the Collocatrones University Professor and Chair of the Department of Global Health at Harvard Medical School. He is also Chief of Global Health Equity at Brigham and Women's Hospital and serves as the United Nations Special Advisor to the Secretary General on Community-Based Medicine and Lessons from Haiti. This is not to mention his overflowing trophy case of humanitarian awards, including the prestigious MacArthur Fellows Genius Grant. In fact, when you look at everything that he's doing, the only thing that seems to be missing from his repertoire is a red cape. His hundreds of scholarly writings continue to inspire students and his colleagues, especially in his untapped perspective towards healthcare equity. Dr. Farmer has been able to examine systems of injustice with a new vision and attribute them not to cultural failings, but to poverty, inequality, and human-created systems of power. From Dr. Farmer's biography, Mountains Beyond Mountains, Tracy Kidder coins his nickname, the man who could cure the world. Though the name may seem to many of us as idealistic, Dr. Farmer's message of hope and his call to mobility to care for the poorest among us inspires us to devote our own lives to continuing his work. Paul Farmer has been able to start a revolution with his call to social responsibility. And when we answer this call and live his message, we will one day cure the world. With that, please join me in welcoming to Boston College, Dr. Paul Farmer.
Chris, come back, you could just go on forever and ever. Jim, you've been upstaged. Speaking of Father Keenan, I will just begin this by saying, you know, when Father Keenan tells you to do something, you say, yes, sir, how high do I jump? So he asked me to come up with a, how come you always ask me to do the inaugural things, by the way? But he asked me to come up with a zippy title, and I thought, wow, this is such a great title. Then I came to regret it, because now I had to write a whole talk around it. However, it's the least I could do, since Father Keenan did not mention to you that when he asked me to write something for his AIDS book, I sent him a chapter called Condoms and Coup d'etats. Which, by the way, in this book, my favorite part about that book, I don't know if I'm allowed to say this, but I'm going, yeah, he remembers. So, the super ultra lefty press, which I will not mention by name, but which is in Maryknoll, New York, which published the book that Chris was so kind to reference. Because it's a Catholic publishing house, they have to get something called nihil obstat, which I like just knowing 2 words in Latin. People say, oh, you're in medicine, don't you have to know a lot of Latin? I said, well, in the 19th century, yes, but that's long gone. And Michal Obsat, no objection. The bishops have to, say, boom, okay. They rejected our book. That was the best part about it. I mean, that's what makes really good cocktail conversation. I had a book, we had a book together, rejected by the bishops of that state, which I won't mention. Anyway. Am I getting you in trouble? No. All right. So anyway, I've come a long way from Condoms and Coup d'etats. You gotta admit, that's a very good title. One of the things, though, was that there were some errors in there. And I'm glad to mention them here. The errors were not errors of scholarship, but errors of undue pessimism. Back in 1999, looking at what had just become the world's leading infectious killer of young adults and a leading infectious killer of children, there was no equity plan in sight, 1999. And a lot of the predictions made in that book, not the exhortations and the counsel and the advice and the analysis, those were solid and right. And of course, this is an edited volume. Lisa Cahill's in the room today, too. The part that was wrong was the undue pessimism about what would happen if we were to have an equity plan. And so I decided, as a tribute to Jim, to come up with this very groovy title, which, by the way, I'd also proposed for an article in The Lancet, rejected again. So, slogan versus mantra. I don't even know how to pronounce mantra. If I repeat it enough times, they'll all get it. Isn't that? That was a very, I'm going to tell them, that was a very insightful joke. Anyway, what is the difference between a slogan and a mantra? Mantra. What is it? I mean, it suggests that there's something wrong with slogans, right? That they're empty somehow, that they don't have any link to real substance. But that need not be true. I mean, this one's a good example of a slogan, Health for All by the year 2000. Is that what it is? Yeah. By the way, speaking of WAGs at Harvard, Chris, I have a very good job at Harvard, so that's part of your answer. A friend of mine who is a well-known physician economist who is deeply involved in health policy, I would talk to him because I felt like it was a different world. Again, I'll get back to this undue pessimism in a second. And I said, what do we have to do to get equity front and center in healthcare policy? I said this to someone who helps define healthcare policy and is clearly, was and is a progressive who believes in Health for All by the year 2000. He said, I have a great public health joke for you. So, but there are public health jokes? And he told me this one. When it was, people was getting, right before the year 2000, this, by the way, was the slogan from the Alma Ata conference in 1978. I'm sure you've all been to Kazakhstan. I have, actually, love it there. This is the great slogan of the 70s, when there was, some people would say, undue optimism. Health for All by the year 2000. So my friend says, well, it was a typo. It was supposed to be Health for All by the year 3000. So I think you can see why undue pessimism can strike. Between 1978, this uplifting slogan, and the year 2000, AIDS, tuberculosis, and malaria alone killed 6 million people. There was no vaccine. There is no vaccine for any of them, but there was therapy for each of them, but there wasn't an equity plan. Now, I'm lucky enough to be able to take the long view and to work with amazing people. In fact, 3 of the founders of Partners in Health are here tonight. They don't like it when I call them out. Ophelia Dahl, Todd McCormick. Anyway, I'm lucky enough to work with a great group. A lot of my coworkers and partners in health are here. Because you can't do anything to take on either undue pessimism or the lack of an equity plan without coworkers. We count ourselves, just with Partners in Health alone, as 18,000 people working in more than a dozen countries. And the other is, sometimes it helps to take the long view. Here, let me give you this example. Things were really very bad for some thousands of years. This is my version of history. I mean, okay, so the data is a bit of a projection, but more or less it's true. Things were very bad for some thousands of years. When was Adam and Eve again, Jim? Lisa? Thousands of years ago, right? And then things started improving. And they improved very precipitously. That's basically the history of medicine and public health, all in one graph. And life expectancy, or death expectancy, there's a pretty legitimate ways to measure how optimistic or pessimistic we should be. Now, if you're looking down on the species, ours, you'd think, well, you know, it's all gravy after this, 7 years. But then you have to start looking at disparities. And in fact, my Catholic theologian friends here have insisted that we proceed in that manner always and everywhere. And it's a very different, oops, it's the same graph, a very different picture when you're looking at the difference between the poor and the non-poor. You know, these are crude measures. Obviously, the first one's crude, but developed nations, underdeveloped nations. Inside a developed nation is an undeveloped nation. Inside an undeveloped nation are rich people who have lives very similar to ours. Most of you know that. That wasn't the case back when we were guilty of undue optimism and undue pessimism. It wasn't for me in any case. And I think we can say that for most of you are Americans, but if you look at the BC undergraduates today and compare them to undergraduates when I was an undergraduate, it's a very different register, very different way of seeing the world, of understanding the world, and very much more advanced. Now we can think about healthcare disparities globally and locally at the same time. And that's how I'd like to open this lecture series, by insisting that we do so. I met with some students earlier and had a very great question from someone who stayed after, who asked a question that we hear a lot we hear it in medicine, we also hear it in anthropology, and that is, when there are things about a culture that are repugnant, do we just shrug this off and say, well, it's part of their culture? And I said, look, I'm going to be honest with you. On this scale of engagement in universal values and the social construction of all values, I'm really on the universalist side. That cruelty can be identified across culture, that suffering can be identified across culture, and that being dead is very different from being alive. And being maimed is very different from being whole. And valuing others, whether you know them or not, is of universal significance. So I want to look at, for my inaugural lesson, that's what the French say, inaugural what? Whatever you call it. I want to look at universal ethics. Now, come on, that took some effort, Jim. And think about some paradigms. And again, I wish I could have done this when I was a student, a medical student, an anthropology student. I couldn't. And it may not be particularly sophisticated, but at least it is something hard-won. Thinking about different paradigms of understanding the importance of health and human rights. These are all fundamentally ethical paradigms. And let me give an example of how they vary. So first of all, come on, aliens? I mean, that's the weirdest thing for me about, once you get beyond nationalism, you guys are beyond nationalism, right? I mean, you're Catholic, right? So once you get beyond nationalism, you see the flaws of any system that confers rights to citizens alone. I mean, the first human rights declarations were either about the rights of man, leaving out the rights of women, rights of children, or they were about the rights of the citizen. And I think one of the things that I've learned from some of the theologians gathered here, and sitting rather intimidatingly close in the front row, is that these are not whole paradigms. Because the first question that you would ask is, well, what about the rights of the non-citizen? And the absurd language that we use, aliens, that's my favorite. This looks like an alien, right? I mean, I don't even have emojis, and it looks like something on there. It's great to fight for the rights of citizens, but in medicine, for example, in health and social justice medicine and liberation theology, I'll get back to that in a second, that's one of the things that I've admired in my work here in the United States at the Brigham and Women's Hospital, for example. If I call a consult, that is, I ask an orthopedic surgeon to come and see a patient in the emergency room who, let's say, has a broken hip. The surgeon is not going to say, well, where's the patient's green card? What's the patient's citizenship? There's a wholeness in this practice, or what should be whole, of saying, well, I'm here because this is a human being with a human femur fracture, and I'm going to fix it. And that's different from the rights of the citizen. And certainly different from the rights of man. And just going back to this idea that Chris was very nice to underline its significance to me, the idea of a preferential option for the poor. It sounds so straightforward. Actually, the last time I was here, Jim, clearly you forgot, was to discuss the impact of liberation theology on our work, our collective work as Partners in Health. Partners in Health is a secular organization, but it's been very deeply marked by some of these ideas that came from liberation theology. And I can remember almost the day, or at least the week, when, and I was reading, as one does in Haiti, I was reading Gustavo Gutierrez. And I didn't know him, of course, back then. But I was reading his books and I was finding them impenetrable. Please don't tell him I said that. I still find them impenetrable, by the way. And because I wasn't familiar with the theology. And even the biblical citations were beyond me. I mean, I can read a chapter from Mandel's textbook on infectious diseases, no problem. But theology, heavy going. And it just illuminated, I mean, this experience of living and working in rural Haiti and seeing that there had to be some way of going beyond the rights of the citizen, the rights of man, the basic minimum package. That was the language used in healthcare. And it was preferential, for me it was preferential option for the poor. The idea that what theologians intend by this is, yeah, well, God loves everybody. He just loves the poor more. And the revelation for me was, well, what if medicine were practiced that way? That there is a notion of universality, but it will be bent towards those in greatest need. Those who would benefit most from the tools of this profession. Even in the mainstream human rights language, this is from the Universal Declaration of Human Rights, there is a preferential for option of the poor for anyone who's concerned about the right to housing, to a job, freedom from want. The notion of a preferential option of the poor is front and center. And certainly if you followed classical epidemiology, following the pathogen, it would lead you right towards the pathogen's preferential option for the poor. And I don't just mean infectious pathogens, although I'm going to do what Jim Keenan has suggested in his writings and give an example from AIDS, it's not just infectious pathogens, right? It's pathogenic forces. Clearly, they make a preferential option for the poor. So to have any professions, law, teaching, medicine, public health, be targeted preferentially to the poor, that would be, then we'd really deserve your praise, Chris. Because the gold standard that you mentioned, or someone said gold standard, not in the old weird presidential candidate type gold standard. The idea of something that is at the top of value, the idea of targeting that toward the poor, that has never been realized yet in medicine or public health. And Partners in Health is part of an effort to bring that into view, but we've never once succeeded. Now, as for an excess of pessimism, I'm going to say there is ample reason for us to believe we will and must succeed in making a preferential option for the poor. Now, I have mentioned already now a couple of frameworks that are universalizing and universalist frameworks. A human rights framework, which has got the H word right in it. It doesn't say man, it doesn't say citizen, it's human rights. And it's a very, very elastic kind of notion. Another one is a preferential option for the poor, which is radical in its engagement on behalf of those who are living in poverty, who are also very often, as you know, living with disease and pathogenic forces. But there are still others. This is one of the classics from, I said I was only going to talk about infectious pathogens, but come on, this is a cool photograph of someone actually sneezing. Could you please appreciate that? Back when, actually my friend Ophelia Dahl gave me this book, but back when Thomas when Thomas Mann wrote The Magic Mountain. Anybody read that? Oh wait, you don't read books.
Denise the book. I did that with a passion.
Yeah, well, it's a long book. It's a long book. I didn't really get through it, but I have to say this publicly. In any case, it's a sanatorium for tuberculosis patients. And you just get through the first 50 pages and you realize which tuberculosis patients could be living there with their multiple meals. It's a chateau. And a lot of sanatoria were like that. They weren't for poor people with tuberculosis. But something happened. It was clear from the late 19th century that this was an airborne disease. And part of the work of sanatoria was to remove people with active pulmonary tuberculosis lung away from the general population. The term was already used back then. It had some significant effect on the epidemics in Europe and North America. How much depended on how many people could have access to places like this. But what did we not have back then? Effective therapy. Surgical therapy was sometimes effective. And in fact, in my line of work, clinically, we're seeing patients now who are sick with drug-resistant tuberculosis, the strains are resistant to almost all the antibiotics we know. And they are also, again, being treated with some of these surgical techniques. But something radical happened in the mid-20th century, and that is the development of effective therapy. And those of you who are not tuberculosis specialists, they're getting it now, Jim, may not know this, but the term used for TB treatment was chemotherapy. In fact, combination chemotherapy. We still call it combination chemotherapy in my field, but then no one reads our work. Combination chemotherapy meant we learned the hard way that you can't treat chronic infection with one drug. You need multiple drugs. So tuberculosis, first drug came along with streptomycin, a very effective drug, but when used as a single drug, a single monotherapy, what happened? People developed resistance. The strain became resistant to streptomycin. So you'd see this sometimes miraculous clinical response. Adults, children, the promise of clearing out sanatoria, people getting to go home, people who've been removed from their families for years, often to die anyway of untreated TB. But now there's this miracle drug. The problem was it wasn't enough. And then other drugs came along, were discovered. Isoniazid, rifampin, ethambutol, pyrazinamide, paramino-salicylic acid. But always and everywhere they were used too tardily or one at a time. I found articles from the 70s about a new miracle drug, rifampin, in which it is claimed that it will never be cost effective to use the drug rifampin as a first line of therapy against tuberculosis. Of course, it is the first line of therapy now, but what strikes me is that this pessimism about possibility invaded the medical and public health literature even back then, before the heyday of an economic reductionism that is still at play in medicine and public health today. Half the questions that one would feel in an honest discussion, an honest and careful discussion, half the questions that one would feel, even if you're a clinician, that is a doctor who sees patient, not an economist, half the questions are about, is something sustainable? Is it cost effective? How is it justified? How does it rank among other competing claims on our resources? So this socialization for scarcity has marked medicine and public health for the poor for a long time, at least since the beginning of the modern chemotherapeutic era. Now let me just say that when these medications were sold as commodities, tuberculosis medications, what happened? I already told you one side effect, drug resistance. Once a strain of tuberculosis becomes resistant to the drugs used to treat it, it's spread as a drug-resistant strain. So the next person or persons who inhale it and get sick with the disease, they wouldn't respond to therapy with the drugs to which that infecting strain is resistant from the get-go. I did it kind of intimidating to have a coloratura soprano in the background. Another outcome, of course, is just that people don't take the drugs. They don't have access to anything that's a commodity. If the pathogen makes it the preferential option for the poor, which it does, no study would claim otherwise, and the drugs cost money, or the diagnostic, an X-ray, a lab test, then the treatment doesn't work. And if it's an airborne infection, that means that the transmission doesn't stop. So rights versus commodity is a matter of life and death with tuberculosis, not just for people who are sick with tuberculosis, but for anyone who could be infected by this airborne pathogen, which is pretty much everyone. 2 billion people in the world today probably are living with viable mycobacteria somewhere in their bodies, a third of the world's population. And so the tuberculosis world became one of the areas in which commodification of therapy was contested from the beginning. It's hard to buy these drugs in the United States, the temple of commodification, because they're available for free as a public good for public health. You have the right to diagnosis and care for tuberculosis. It's not perfect, but every time there's been an attempt to privatize or to introduce user fees, as they're called now, that is, you need this medicine, you pay, here's your copay. It's failed. And people, another question I had from a student today is, what about when people don't agree with you? And I want to say, that's like every day, all the time. But you have to agree, if you don't want this pathogen to spread, that selling it is not a good way to respond to tuberculosis. Now, how many of the pathologies that we see every day are regarded as threats to public health. Some infectious pathogens, but what about drunk driving? What about handguns? What about, go right through the list, what about the kind of food we eat or the size of the soft drinks we buy? Now, this is highly contested in this country and in others. But that's a leap that we make collectively. What are threats to public health, and what are the responses that we wish to have collectively? Now let me give an example that is not airborne. It's still an infectious pathogen, HIV, and I just was reading this. Did I mention I like to read Jim Keenan stuff? Basically, the claim that he makes here, highlighted, circled in red, is that the HIV has changed the paradigm that we use in thinking about public health threats as global, and that's a good thing. It should change the paradigm. In fact, the invitation for this lecture was to talk about universal health care, which, interestingly, this country is a place where it's discussed less than the other places in which we work. In Asia, this is across Asia, regardless of political ideologies or what kind of governments are at play, universal access to health care is already on its way to becoming universal. And it doesn't mean that the problems of how to ration scarce resources are solved, but it does mean that people are saying, well, wait, without this, the expenditures are even more significant. Some people can do the math on that. Here in the United States, it's been a difficult and tardy discussion, but look what the United States has done around AIDS. I think that all of you should be proud of this, and I know I am. Now, if you have a commodity, this is, by the way, interestingly, this was in the same year, in 1997, these two, an excess of optimism and an excess of pessimism, right? On the one hand, same magazine, the advent of therapy, effective therapy, now it's not curative, but it's suppressive, like insulin for diabetes, right? Not curative, but can make you feel whole, well, healthy. The prediction that this spelled the end of AIDS. Perhaps an excess of optimism, but an excess of pessimism was the other story, which again, I'm embarrassed to tell you, I found more compelling back then, that some people were being dismissed as just too poor to treat, right? And what does that mean? It means, in a way, that the commodification of the therapy, or the diagnosis and the therapy, put this out of the price range, and that was a language that was very often used, of people living in poverty. And in this country, it's people marginalized by racism, gender inequality, distance from a center where this could be readily had, failure of state governments sometimes to even ask for the resources to treat the poor of their own state. This happened all the time between the mid-90s, when effective therapy was first described, and it's still, in some places, a sluggishness to ask for these resources for their own citizens. Now, I happened to be, in that year, what's called an infectious disease fellow. That meant that I'd finished my training in internal medicine and was specializing in infectious disease. This was at the Brigham, the Dana-Farber, the Deaconess Hospitals, Harvard's teaching hospitals. And I can tell you that it was a miraculous thing to see. To be an infectious disease fellow, or even a physician or a nurse of any stripe in those years in the Harvard teaching hospitals. The Harvard teaching hospitals were full of people who were dying of AIDS. It was the leading infectious killer of young adults, as I said, and people came in often to the hospital and spent their last days there, often uncomfortable, miserable, usually. And then in one year, 1996, something began to happen. People began the treatment with, again called combination chemotherapy. They got up out of their beds and went home. And many of the people I met in those years are still patients of ours today. I mean, I'm more likely to bump into them at a grocery store than in the Brigham. So if you were doing what we were doing, and I'm looking at my colleagues and partners now, the movie between Harvard and Haiti, what was the dilemma? On the one hand, the one end of that trajectory, I was begging our patients to take these medications. And on the other end of the trajectory, patients were begging me to find them these medications. And I will tell you, because we had a fairly sophisticated discussion about how the notion of sustainability is used, that is not sustainable. Not for me as a physician or a person. Some persons are not physicians. That wasn't sustainable. There's no way that you can go back and forth between Harvard and Haiti 3 hours, around 3 hours to get from the Brigham Women's Hospital to Port-au-Prince and halfway to central Haiti. And there's just no way that you can tolerate that kind of disparity. And an excess of pessimism sometimes played itself out in our unwillingness to see that there was another alternative. Now, I'm glad to say it didn't last long, and I have a great debt to some of my friends who are AIDS activists, who began talking about the idea of some kind of fund, a super fund, to help bring this miraculous therapy to people living in poverty. I remember 1996, again, Vancouver, that was where the AIDS meetings were. People weren't saying, where's Paul back then? Same meeting, different city. And some of the folks from ACT UP, themselves the beneficiary of antiretroviral therapy, and to this day, coworkers and friends of mine, were saying we need to think about people in Africa, people living in poverty with AIDS in Africa. And let me tell you, they were scoffed at behind their backs. People say that's completely unrealistic. It's not sustainable. It's not cost effective. $15,000 per patient per year. And then some people said, but why? What are the drugs made out of? They're $15,000 per patient per year. Platinum or some rare substance that can only be had under the earth? Or maybe we can actually make them in China. Well, let me just say, the experience of being a physician in Haiti, and later on, this is a patient from Rwanda. His name's John. He said, please, use my photo. Don't I look great? I said, well, actually, you gained too much weight. One of my students said, and I'm sure Ophelia and Todd are tired of hearing this, but he goes from looking like Skeletor to looking like he needs Lipitor. But the point I'm making is, an excess of pessimism occurs when we can't imagine the scale of the response that we need to see. 6 million people dead of AIDS, tuberculosis, malaria, when we have treatment for all three. This causes you to feel defeated, pessimistic. But when you see this at the level of a person, a family, a community, a village, a city, a district, a nation state, then you start saying, we were way too pessimistic. And some pretty miraculous things happen. I'm not just pandering to my Catholic hosts. They were miraculous. In Haiti, which was chaotic, disorganized, which is chaotic and disorganized, there was a massive turnaround in Haiti. We forget how well Haiti has done as a leader in global health equity in starting this movement. Haiti received the first grant from the Global Fund to fight AIDS, tuberculosis, and malaria. And to this day, in spite of earthquake, political upheavals, cholera, Haiti's done well in responding to AIDS. Now, Partners in Health was lucky enough to be invited to Rwanda. And that's where I think many of us really learned our lesson about the importance of informed optimism. In 2004, we signed up to go there to Rwanda, into rural areas, working with the Clinton Foundation, and of course the Ministry of Health. In the 3 districts to which we were assigned, there were 3 of the 4 with no hospital at all. There was no district hospital. Or 2 were abandoned, and 1 didn't have a hospital, 350,000 people. And the idea was train community health workers, reopen clinics or keep them open, and build hospitals so when people are injured or critically ill, we're not saying, well, you know, it's not really in the budget, it's not part of our plan to do hospital care, it's not cost effective, we really want to focus on the biggest bang for the buck. We didn't say those things. We worked with the public authorities and local communities and people afflicted with HIV. That's how we met this guy, John, who had, by the way, both tuberculosis and HIV disease. And we saw something really remarkable happen. It doesn't look as remarkable as the kind of clinical response you see when someone with a wasting illness, in this case 2 of them, who's also malnourished, receives the treatment for those illnesses and the treatment for malnutrition, which is called food. It doesn't look as miraculous, but Rwanda, 20 years ago, that's not a long time. Look at the scale I showed you in the first graph. 20 years ago, Rwanda was considered a failed state, a lost and hopeless place, worst health indices on the face of the earth, whether you looked at infant mortality, juvenile mortality, maternal mortality. Nobody had an excess of optimism. But what happened there in those years since has been miraculous. Now, they might not use language like a preferential option for the poor. And they don't, in fact, the public authorities. Although they express nothing but admiration for those concepts, not the concepts they use. But when they start talking about, we're going to make sure that the poorest quintile of the population has preferential and first access to care. We're going to make sure that rural people have access to care. Women, children, orphans, and widows of the genocide, that's to me equivalent to a preferential option to the poor. And it wasn't a push in Rwanda for a minimum basic package, that was the language I mentioned already, but a push for global health equity. And that was explicit. And this is the return. And I think of all the great fortune I've had as a physician working with Partners in Health and Harvard Medical School, this is at the top of it. Just 20 years later, to see Rwanda first over the line in universal access to AIDS care is pretty stunning. Pretty stunning. In 2004, when we went there weren't even 150 people on therapy, publicly supported therapy, in Rwanda. One of the leaders in Rwanda said rather wryly, and not in a complimentary fashion, back in 2004, wait, there's like 150 AIDS-related NGOs, including a lot of them being American. You don't even have 150 patients on therapy. That's like one patient per NGO. So it wasn't an excess of optimism back then either. But enough people believed that it was possible that this moved forward. Now, do you have to only treat AIDS? This is another question. Of course not. Well, who cares if it's AIDS or tuberculosis or getting hit by a car, right? They're all going to kill you if there's no response to them. The prevention versus care arguments don't work if you already have leukemia or a head injury or untreated diabetes. But the Rwandans said, and again, I'm making it sound like there was some one cohesive plan. Well, there was one cohesive plan. There, I've said it. The plan was to link the temporary enthusiasms, and this word was used, by some of the leaders there. The temporary enthusiasms associated with AIDS to the broader goal of strengthening health systems that could serve the entire population, which was largely rural, and still is, and which lived in poverty largely, and still does, although a heck of a lot less than just 10 years ago. So these are data from a number of public sources, and I remember when we were, that sounds terrible. I remember when we were writing the MDGs, but I did go to write the MDGs. I did one, Millennium Development Goals. And here we are saying, okay, here's the 8 Millennium Development Goals. I'm not even sure we wholly believed that it was possible. I mean, I'm not proud of saying that. I don't think I've ever said that publicly before, but I was one of the authors, and I was thinking, there's no way we're going to ever meet this goal. But Rwanda met all of their health-related Millennium Development Goals, and probably was the first country to do that as well. Not just around AIDS, tuberculosis, but under 5 mortality. The goals that were agreed upon, this is in the year 2000. Imagine doing this in the year 2000, just 6 years after the genocide, killed 1 million people. To say, oh yeah, we're going to do it, and lo, it has been done. And you know, in writing this paper with colleagues from Partners in Health, which as you can see was published in the New England Journal of Medicine because I pulled it off their website. Oh, those are my graphs. One of the things the editors said to me was, well, this looks really like rapid improvement. I said, yeah, I think it is the most rapid decline in mortality ever seen anywhere. It sounded kind of good. It still sounds good. This is the sharpest decline in mortality ever seen anywhere at any time in human history. Love, Paul. Now, trust me, the New England Journal is not impressed when people say things like that. So they said, okay, well, compare it to other shocking declines in mortality. They actually let me publish this graph. How I got away with this, I don't know. It's not even the same time scale. Too late now, they already published it. Now, that's my conclusion, in a sense. Don't get worried. I still have a lot more to say. But no, I mean, what more can you say? You go from the poorest country on the face of the earth, the most disrupted, Rwanda, 1994, and then you can point to this. What does this tell you about the power of believing something's possible? And again, it's not perfect. It's just better than anything else we've seen before when we're looking at the rate of improvement. Claire Wagner, one of my co-authors, is here. And she wrote this paper with me along with others. We actually didn't have co-authors from the Ministry of Health because we didn't want people to say, well, that's just the Ministry of Health, the government of Rwanda saying this. So we did it ourselves. Colleagues, academic colleagues, and Partners in Health colleagues. But I still feel goose flesh, chill bumps, when I think about this in human terms. And at the same time, as health problems were addressed, AIDS, tuberculosis, malaria among them, but also under 5 mortality, death during childhood, as these were addressed, the cycle of poverty and disease could be broken for families, whole villages, whole towns, which is one of the reasons, and not the only one, that Rwanda lifted hundreds of thousands of people out of poverty by taking on their health problems, the crises, the health crisis. Rwanda now is regarded as a model of health system strengthening and a leader everywhere we go, in Liberia, Sierra Leone, Lesotho, where Partners in Health works, and just started working in Liberia and Lesotho, Liberia and Sierra Leone. I'll close with a reflection on that. Our colleagues in the ministries of health, our public health colleagues in those countries, they know all about Rwanda. They said, how can we do what they did? And the great news is, this is not some mysterious black box that can't be figured out. They made a preferential option for the poor. They didn't call it that, but that's what they did. They built a healthcare delivery system that could reach poor and vulnerable people and rural people. And now they have a lot fewer of those. I just want to close with once again, a Keenan reference, but sorry I didn't get the reference clearly today. But Jim makes this point that I made at the beginning. The wags in health policy talk about the oops approach to healthcare financing, which is out-of-pocket expenditures. Oops. The poorer the country is, the more the poor pay out-of-pocket for poor quality healthcare. Now, it's very expensive to give poor quality medical care to poor people in a rich country. I thought that was pretty layered. Only one person chuckling. It's very expensive to give poor quality medical care to poor people in a rich country. Look around you. Our emergency rooms are the providers of first and last resort, and will be until there is universal health care here. But in the poorest countries, that's where the burden is greatest. That's where care is most privatized. This is not an ideological take on privatized healthcare. I work for Harvard Medical School. Last I checked, neither Harvard Medical School nor the Brigham were public institutions. You don't have a right to go to Harvard Medical School. Well, Chris, you do. The notion of commoditizing healthcare is one of the problems that we're going to face every time we don't have alternatives for those who cannot pay for services. Now, the good news is that there's growing awareness of this in the world. The bad news is that we're sometimes behind the curve, or seem to be behind the curve in this score. And this is not about AIDS, it's not about one particular pathology, but one of the most vivid reminders has been in looking at the weakest health systems in Africa. And I think maybe among the weakest on the face of the earth. Two of those. People ask me all the time, and I'm sure my colleagues, some here and others not here, are asked, why Liberia, Sierra Leone, Guinea? Why those three countries and not others? Well, look at the public expenditure for public health in those three countries as opposed to, let's say, Rwanda. For those of you who love studying health policy, by the way, psychiatry consults for those of you afterwards. For those of you who love studying health policy, you know about the Abuja Accords, in which a number of countries across Africa pledged to spend a specific amount of their public budgets on healthcare and education. Rwanda is one of the few countries that actually met those claims, putting more than 12% of their GDP, did I get that right, Claire? Into healthcare. The bottom of the list were Liberia, Sierra Leone, and not far above them, Guinea. And the interesting thing is that those three countries had much higher rates of growth looking at GDP than most parts of the world. Even in the 70s, Liberia had a higher GDP than any country except for Japan. Who knew? Massive extraction going on in that part of the world, as there has been for 500 years, but not a lot of investments in healthcare. And then came war. Now, after the wars ended, two of those countries just wiped out by civil wars. And don't think Guinea didn't take its share of abuse. No civil war, but at one point, a quarter of all Sierra Leoneans were probably refugees in Guinea. Imagine that. So there, after the wars, which ended more than a dozen years ago, follow the money trail. See how much money went into building local capacity healthcare systems, investing in long-term solutions in healthcare and education. Very little. So this is not a mystery. You know, my first trip to Sierra Leone was in June of 2014. I only knew 3 Sierra Leoneans. All 3 of them were doctors. And by November of 2014, 2 were dead of Ebola. Umar Khan. One of the most painful things about Umar Khan's death is he was an expert in hemorrhagic fevers. Ebola, Lassa fever. He ran the world's only Lassa fever ward in Kenema, Sierra Leone. And he saw his death coming slow motion. His colleagues at Harvard, Tulane, the CDC, World Health, all of us knew he was going to die. He knew he was going to die. Why? Because he didn't have the stuff he needed. Martin Salia, a surgeon. How many surgeons do you think were left in Sierra Leone after the war? 41 years old, had a green card, could have stayed right here in Maryland where his family was. He went back and said, I didn't go train in surgery to not be able to serve people in my country. And just like the others, he knew what was coming if he continued to try and help people, not because they could pay, but because they were facing a lethal and rapidly spreading epidemic. The third, I'm happy to tell you, is working full-time for Partners in Health, Violet Berry, and is a student of ours, but took a year off from Harvard Medical School to go back and work with us there. Now, I don't want to end on a note of anything but an excess of optimism. The last 40 years has shown us that investments in health and education as a matter of social justice, as a matter of ethical principle, has had some of the greatest returns on investment that we've ever seen. We need to keep fighting to understand how to measure those returns so that we can fight back against an economic logic that, frankly, leaves us wishing to commodify everything, including access to healthcare and education, and to further erode the notion of basic rights, or at the very least, public investments in public good. And that is a fight well worth engaging in. Indeed, for many of us, the only battle worth waging. Thank you very much.
So we have time for just about 2 or 3 questions. If you have a question, there's a microphone there, and there's a microphone there. This is going for about 7 minutes. We're going to adjourn at 8:20. 6 minutes. Okay.
Great talk. It's very inspiring. I was just wondering, how do you think the role of good governance plays in the improvement of health?
I think there's little doubt that good governance is preferable to bad governance. You want to write that down? You want to get back in your seat? Yeah. You know, the questions that I think a lot of us have are almost pragmatic ones regarding conditionality of support. If you're making a preferential offer to the poor, or again, to use Rwandan and language of the poorest quintile, that by definition, the poorer the setting, the worse governance will be in the sense of, I mean, just to give a very vivid example, this is vivid for me. When it was announced that Haiti would receive the first Global Fund grant in 2002, this was an AIDS grant, I was in clinic seeing patients in Conge, which was a former squatter settlement, and a woman just barged in. You knew it was an American if they're going to barge in. And she said, "I'm so-and-so from NPR." I said, "Well, that's enterprising of you, but I'm Paul and I'm with a patient. So could you wait?" She accidentally left her shoes in my office, by the way. Anyway, I did talk to her after finishing with this patient, and she said, "You know, what about good governance?" And I just thought, wow, what an opening question. I said, "Well, you know, we have a little electricity problem here, and nobody has computers, and all the accountants are working for Enron, and, you know, so the way that I know you're using it, that we want to use resources prudently, effectively, accountably, that can only be good for poor people's health. When notions of what is good governance can turn a blind eye to just massive diversions of funds. I mean, I was only half joking about Enron. You know, you look at some of the military adventures, very expensive, also no accountability. When that is used to block transfer of resources to the poor, I think we're in trouble. And we need to line up to offer the tools of good governance on behalf of those efforts to promote health and social justice. And it will require things like electricity, numeracy, literacy, bookkeepers being taken from, you know, crazy New York financial crap, sorry, moving them towards public goods. Love, Paul.
Hi, Paul. Thank you so much. I find myself wanting to jump up and clap almost every other sentence you say.
Well, keep going.
You're
more than welcome.
I wonder,
My foolish friend.
I read something of yours where you called not addressing the climate crisis, our generation might be looked back upon as the great procrastination. I wonder if climate change is similar to public health, where without a preferential option for the poor, we simply don't get done what we need to get done.
I think that the answer is for sure yes. And I say that without any pretension of expertise about that topic, which is something one should say shamefully, right? Because if we think it's okay to not understand these problems because they seem complex, that's not acceptable. It's like saying, look, you know, we can't understand the epidemiology of HIV and blah, 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 blah. Jim Kim is now the president of a small multilateral financial institution based in Washington, and has very compellingly argued that the poor will be the primary targets, if you will, of adverse outcomes from climate change, and that only a preferential option for the poor is going to bring in relief what needs to be done to protect the most vulnerable from the impact of climate change. And I think it's the same sort of blindness and procrastination that we've seen. And let's just hope that, like with some of these epidemics, we can turn things around in time. But only organized and informed advocacy is going to be adequate.
Hi. Over here.
Hi.
For my intro to public health class, we had a consultant in she works for some consulting on public health, and she was saying, so this is in relation to what you were talking about at the end, about how much you should spend more on you know, public health. And she was saying how in the United States, we spend like this dizzyingly high amount of money going into Medicare. It's like a huge portion of the budget every year, and like, you know, different people are like, oh, we always have to decrease it, but we have the least returns for it. So I was wondering, how do you square that with your, you know, look at countries that push all their money to healthcare, and like, is there a difference between how the United States does it versus how they should be? And
yeah, that's a great question. It will take you 17 minutes to respond to it. You know, just one thing about that, I wasn't making a plea for blind dumping of money in unwise expenditures, wasteful systems, unnecessary procedures. what I'm arguing for is investment in global health equity. And Boston's on the globe, right? And Washington, D.C. is on the globe. Although sometimes it does seem like alien territory, actually. Now, one thing I would say, just give one example. What are some of the lessons learned in Rwanda that we should be using here? Well, one is to have a healthcare system. Another is to think about universal healthcare. Again, I'm embarrassed to say all these confessions, but when in 2005 the notion of enrollment in a health insurance scheme was advanced in Rwanda, as a universal target, I was a little skeptical. I didn't say it out loud very much. Within a few years, 90% of the population was enrolled in that health insurance scheme. Another example that is critically needed in the United States, community health workers. We don't have any community health workers, so we treat chronic disease in hospitals. We ask elderly, infirm, frail, or just disorganized people like me to go into the hospital for something that should be better done at home or in the workplace, or at most in a clinic nearby where they live. These kind of inefficiencies are well identified in the United States healthcare. And now again, if you're going to have a heart transplant, go to the Brigham, right? But for a health system, we have a long way to go. We have a lot of lessons to learn from places like Rwanda.
Thanks.
Thank you.
Thank you very much, Dr. Paul. I'm actually from Rwanda.
How'd I do?
So,
Akazi Keza?
It's really a wonderful and pleasure to hear you speaking about Rwanda. 22 years ago, we were known of a country of the genocide. But today, given your lecture, the image changes. So it's really, I feel uplifted. So in some way, I really wanted to thank you. And secondly, you might not have used a theology language. I'm a Ph.D. student. But I wonder what really moves your work. So beyond the science, I think there's something more. What is it that really gets you into this work, together with the partners of health? I think it is not just the science you have learned. I feel there is some theology working behind your organization. That's one. Secondly, are they also
I hope you'll forget the first question. Second, go ahead, sorry.
The second, then I shut up. The second, are there challenges that you have also encountered in working with governments?
Yeah.
Those are my two questions.
Those are great questions, and thank you very much. And I had to make a little joke because it's my way of not getting too choked up when I think about. Anyway, where were we? So let me, I heard this latter question from a couple of students today, which, by the way, was just a terrific. I enjoyed it very much, getting to meet. Everybody seems to be doing this new program in medical humanity. What? How did you do that, Amy? Yeah. So one of the questions that we talked about was working with governments. And a couple of things come to mind. One is, when you think about rights paradigms, human rights paradigms, this is very unoriginal what I'm about to say, but you think about rights paradigms, like how are rights conferred? The right to vote, the right to clean water, the right to whatever. It's not through NGOs. It's not through church groups. NGOs and church groups, and I've already said I work with two NGOs, one Partners in Health, and the other a small community-based college in Cambridge, Massachusetts. But we can all be part of the struggle to improve access, realization of rights by working with governments. Now, I sometimes think I mean, I said this today, not knowing you were in the audience. I said, what if we'd been there in 1992? What if we'd been there in 1993? But it's just, there are times when we feel terrified by just the thought of having been in the position of making that error. Because not all governments are potential allies. Some are violent, murderous even. So the process of what they say in a place like Boston College and in your field of discernment is critical in public health. It's been critical to our own decision-making. Ophelia Dahl ran Partners Up 15 years and was one of the founders. She, Todd McCormick, and others of the founders know that we have had to struggle again and again with these questions. How and when and why are we working with governments? And that's been true in Rwanda, Lesotho, Liberia, Sierra Leone, Haiti, etc. Think about Haiti, 35 years soon. We've been working there. Imagine, there have been more, I was going to say more coups than you can shake a stick at. It's a little bit too colloquial. But, you know, there's in the space of just a decade, your partners change from a democratically elected government to a military regime that's unseated that government. So knowing how, knowing why is important. I've said why, but knowing how. Sometimes you're working with local governments, community councils, district authorities. Sometimes not at all. I'm just working with, again, women's groups, village councils. That doesn't give you the scale that you'd like to see the turnarounds that we've documented in Rwanda and elsewhere. But there are times, no doubt, when it's the right thing to do. And it's a tragedy for the people, of course, not to have a government that can promote basic rights, like the right not to starve to death or the right to be safe in your own home or your own village. You know, even without getting theological, and I'll get all theological with you, my friend, but even without doing that, I will say, beyond science, human connection has been very profound, I think, for a lot of almost all of our coworkers at Partisan Health. Sometimes it's a community health worker in rural Haiti. Sometimes it's the daughter of an actress or the son of a prominent businessman or a Harvard medical student, but that connection across some sort of boundary or gulf or divide is almost always important. I've seen it happen with people working with Partners in Health in all the places we've worked. And so even without looking for a justification from Christian theology, say, or Catholic theology, that human connection is at the heart of this work. And accompaniment is the means by which we can make that connection last.
So that was a good inaugural lecture. And the next project I come up with, you'll be the inaugural speaker too. It's my job to just tell you what we're doing next, and that is that on next year we're launching 7 talks all through the Park Street Corporation, and the first one is on September 15th with Nick Kristof and Cheryl Boudin. So think of that on September 15th. But in the meantime, think of Paul. Take care.